We next move on to a very, very interesting, but what I would call a very difficult topic, both for the ophthalmologists and for the neurologists, diplopia. We have Dr. Navin Jaykumar. He is co-director of Darshan Eye Hospitals, Chennai. He also heads the neuro-ophthalmology department of Vasan Eye Care. He is visiting honorary professor to Shanto Medical University, China. He has also had fellowship training in USA in neuro-ophthalmology. Dr. Jaykumar.
Thank you, sir, and good morning. So while my slides are coming on, I thought there was, Subhadra, you gave an excellent talk. I was just thinking about the last thing that you mentioned. And I have to add that there's nothing more irritating or frustrating than dealing with patients who are malingering. Especially the easy ones are those who say they can't see anything at all because it's easy to prove the existence of vision. The terrible ones are those who say refuse to read more than 660. And they eat your time up and they don't pay more than your consultation fees. And the only way to get your money back is to do fields and do VEP and all the tests possible, I think. There is no PPT in this. Can I just... How can there be nothing in this? Here. So, I have the pleasure of spending the next 45 minutes with you, talking on diplopia. And essentially what I decided to do was to present this in about 10 to 15 video clips. And also I would appreciate if some interaction happens between the two of us, between you and me, because some things require interaction as well. So please feel free to make mistakes and say whatever you want to, and we'll proceed from that. So apart from telling you that it's going to take about 45 minutes, I also wanted to tell you that this entire talk doesn't contain even a single slide on neuroanatomy, so you can just relax. It is a completely clinical approach to how we would handle a patient with double vision. And the most important thing is to inquire very carefully from the patient as to what exactly his complaint is. Is it a blurred vision? Is he seeing double? Where exactly is seeing it? And most importantly, therefore, the first question is this a neuro-ophthalmology? Is this my problem? Or is it a general ophthalmology case? And most often, even as recently, a patient presented with double vision who had all the tests, including MRI, done, and was found to just have a little bit of refractive error, improving clear single vision with a pinhole in each eye. So these are common mistakes which can happen. And so it's important to know the causes of monocular diplopia. And the first question, therefore, you ask the patient is, are you seeing double with both eyes open, or are you seeing double or blurred vision, or whatever it is that you're complaining of, even if you close one eye? Okay, so please do make that distinction. The text marked in yellow is an extremely rare condition. It is just there for completion. So I don't want you to pounce on that and say a patient has this in a monocular diplopia. Okay, that's the last thing that you'd ever see. I have not seen a single case so far in the past 25 years. Think of refractive error, think of cataract, think of macular disease, and things like this for monocular diplopia. The symptoms that we may complain of is, of course, double vision and squint. All of you know that. Patients come with that. But more interestingly, patients may complain of very slight double vision, where the diplopia is not exactly two images. It's just a slight separation of the image, but it happens more in one particular direction. If you had a cataract and a slight blur, it would present in whichever direction the patient looked at. But a blurriness of vision which happens only on looking, say, to the right or looking to the left is very suggestive of a slight ocular misalignment in that particular direction. The presence of double vision is also extremely disconcerting to patients, especially if it's vertical, and patients might slip and fall, and giddiness can sometimes be therefore a complaint. Also, patients can sometimes complain of quite a bad headache, and that might not be due to a neurological cause. It might be very simply that the patient is squeezing his eye closed in an effort to see single. So he's trying to just do that, but trying to squeeze his eyes. And the spasm of the muscles here produces a headache. And that kind of diplopia can be very easily treated by an occluder on that particular side. So the next question that we need to ask more questions, and in fact by the time you're through with the questions, you have a very good idea as to which is the muscle that is kind of playing up. So are the images separated horizontally or vertically? So if it's a horizontal separation, you're dealing with horizontal recti. If it's a vertical separation that is more prominent to the patient, you're dealing with the vertical recti or possibly the obliques. In which direction of gaze is diplopia the worst? Is it worse when you look to the left? Is it worse when you look to the right? So obviously, where the double vision is worst, that's the direction of the weak muscle. Variability is very important. We can never always have to keep myasthenia in mind, where the diplopia changes and is worse in the evenings. Can anyone tell me where diplopia might be worse in the mornings? Very good. Thyroid ophthalmopathy. That's one thing you need to keep in mind. Of course, look for the other symptoms of thyroid eye disease as well. The other things I would like to focus on in the history is, are there any ischemic risk factors? So the presence of diabetes, the presence of hypertension, hypercholesterolemia, smoking, and these are things which we need to ask as well, because they play a role in the possible etiology that we are trying to think of. Diplopia in the elderly, even though they may be having a bit of diabetes or hypertension, which is quite common, always think of the signs of giant cell arthritis, especially if they complain of pain, and they are reasonably in the elderly age group as well. So it's always worth it to test for giant cell arthritis, at least include an ESR in your testing. The potentially lethal conditions which can cause diplopia, aneurysms, are common in third nerve palsies. So does the patient have the worst headache of their life? How bad is the headache? These are things worth asking as well. Head trauma. The reason I put up this question of whether it's obvious or trivial, I'll just illustrate with a story. My professor, Dr. Neil Miller, once told me this story of a resident of his who said he saw a patient with a sixth nerve palsy. And so Dr. Miller said, so what happened? He had an injury. So what exactly was the nature of the injury? He said the patient fell off a ladder. And many of us might stop at that history. But Dr. Miller happened to ask, well, how high was he off the ladder? And the answer came that he was just fell off the first rung itself. Okay. Now, that is not enough injury to produce a nerve palsy. So they did a neuroimaging for him, and he had a sixth nerve palsy, but he had a tumor which was stretching the sixth nerve across it. And when a nerve is stretched, it is more prone to trivial injuries. So always in a traumatic nerve palsy, ask about the nature of the injury. You can get a traumatic nerve palsy if if you got banged by a vehicle and you fell off the road and you hurt yourself, but not if you just bumped your head just now and slipped here. Okay, so keep that in mind, and trivial injuries need definitely neuroimaging as well. And also obviously ask for other CNS deficits that might be there as well. So now we proceed to the general examination. You've taken a good history, and now I think by now you should be having a fairly good idea as to what you're dealing with. And even while you're asking the history and noting down what the patient is saying, it's a good idea even before you speak to the patient and you greet them and you observe the way they enter the room. And quite often a fourth nerve palsy can be picked up by the way the patient walks into the room with his head tilted to one side. So a compensatory head position is something you look at. There are 3 components which are listed there. So patients may have more than one component, so it's a good idea to write down which of these components the patient has, and you know what they mean. I won't waste too much time on that. The next thing is, of course, pattern recognition. Now let's proceed to the ocular movements. So you've observed the patient, the way he's keeping his head positioned, and now let's check how he's moving his eyes. And very often pattern recognition is what plays a role in as to what might be the reason for the defect. So here it should be quite easy. Take a look. What did you see first? Ptosis. And then elevation was limited. Adduction limited. Depression limited as well. So if you put all this together, what pattern do you get? What does it suggest to you? Third nerve palsy, isn't it? So one would think of a nerve problem. One doesn't think of myasthenia in this case. Of course, myasthenia can do this also. Okay, but that's not really top on our head list. I think this patient deserves investigations or neuroimaging as the case may be. So what is it that you think now, the single most important thing that in this patient would tilt you towards neuroimaging? The pupil. Very good. So we come to the pupil examination. So looking at the pupil, we look at the pupil because of this risk, the risk of aneurysm. There's a very nice article in the survey by Andy Lee, and we have basically I've summarized that in this little chart here, where you see pupil dysfunction going vertically and the ophthalmoplegia going horizontally. So which are the conditions in these combinations where you would need to do neuroimaging or where you would not need to do neuroimaging? So obviously if the pupil is involved, whether the extraocular muscles are all affected or only partly affected, some of the third nerve muscles are affected, the others are unaffected. Basically, even if it's an incomplete third nerve palsy, if the pupil is involved, these are patients in whom you have to think of an aneurysm. You must do MRI with an MR angiogram. Now, we have another set of patients at the other end of the spectrum, where, for example, in the blue, the pupil is spared, like a typical diabetic third nerve palsy. Spared pupil, complete ptosis like you saw on that lady, elevation, depression, adduction, all completely restricted. These just need observation. You would consider doing neuroimaging if they didn't improve at all after a couple of months or they develop new symptoms or signs. So MRI, MR angiogram, etc., if there's no improvement. At the other end, you have no ophthalmoplegia, but only a pupil involvement. Typically, for example, your Holmes AD pupil or your tonic pupil. Once again, you don't need to image those people immediately. You can observe them and look for other signs. Okay. However, do remember that incomplete third nerve palsies also need to be imaged. They may not have an aneurysm, but you cannot say that they don't have an aneurysm. So you have to image these patients as well. Okay, incomplete third nerve palsy, even if the pupil is spared or if the pupil is involved, you should image them. Okay, so let me get on to this particular point. There's always this issue about anisocoria as to whether how effective is it for us to look in bright, in dark, and things like that. But this simple test is very effective. Any pupil, whatever its size, if it reacts absolutely briskly you can consider that to be a normal pupil. Whether it is 1 millimeter in size or 4 millimeters in size, if it reacts nice and brisk to a good light reflex, it's a normal pupil. Whereas a sluggishly reactive pupil on a direct reflex, whatever its size, is always an abnormal pupil. So keep that in mind. Okay. The next thing, of course, is to look at dyskinesias. We do know in third nerve palsy you have misdirection syndromes where confusion can happen between muscles or and the lid, or between muscles and the pupil. So how do we look for this? This video that I am